It's a very topical issue. On the ESBL, of course. So my slides are actually in English because I was told it was an international presentation, but we're all French, I think, in the room. Anyway, I'm going to translate this along the way. So I'm going to present this for about 30-35 minutes so that we have time for discussion, because I don't have really the absolute solution for the optimization of the management of ESBL infections. So a number of conflicts of interest, but not really related to this presentation. So why is it important? Well, Jean-Christophe has discussed it a lot already, so we'll be brief. The antimicrobial therapy, is there an alternative for carbapenem, and what role for these? And what are the rules for probabilistic treatment, and when should we take into account the ESBL, and when should we use PNMs? And there's a number of possibilities. And what are the rules for documented treatment? How and when do we need to try to not use carbapenems, and when is a de-escalation possible? And also a few words about the duration of therapy and basic rules. So as Jean-Christophe went very quickly over the increase of E. coli resistance, you see what's happening in Bichat on Fotaxine with indeed 40% of resistance right now. You see the situation as Jean-Christophe presented it earlier on, which is rather worrisome if you take into account all of the colibacilli infections on the CG3. It gives you an idea of the situation. And basically, we use more and more molecules that are active on C3GR strains. And even if really this increase in consumption might have slowed down over the last few years for the PNM consumption, it's worrisome. And when you look at the figures in Europe, in Asia, elsewhere, it's even much worse. And Jean-Christophe showed this at the end very quickly. You see in France the increase of carbapenems, plus 25% of imipenem, plus 133 for meropenem, 31% for ertapenem, and 319% of doripenem. So the evolution is not positive. What is even more worrisome is how we consume this, because if you look at the SPACARB survey in 2011 out of 251 hospitals, you see that it was mainly imipenem and ertapenem that were used. 1/3 of cases it was CAI, community-acquired infections, prescriptors not only us, as you see, but surgeons and internal medicine, and some of the sources also for which other molecules were possible, such as UTI, were the first cause of prescription, unfortunately, and documented ESBL infections were not the majority of prescriptions of carbapenem, and alternatives were possible, and there were very few cases of de-escalation, and it happened very late after more than 7 days of treatment in 50% of cases, 10 days in 30% of cases. Same for ertapenem with 2% of cases, and 50% of the carbapenems were stopped only at the end of the antibiotic treatment. So if we look at the intestinal flora, and this was Laurence Armand-Lefebvre in Bichat who conducted this study, when you have a few doses of imipenem, a few days of imipenem for a patient, if you then look in the intestinal flora, the strains that are resistant to imipenem, very quickly, starting with the first treatment, the initial probabilistic treatment, you have a very strong increase of the risk of imipenem R strains. So it's mainly Pseudomonas aeruginosa, but this risk does exist. So your impact on the ecosystem is immediate. First, the ecosystem of the patient, before speaking about the ecosystem of your unit and even the community, because you know that it goes into the sewers, all of these antibiotics, tons of them, and germs that are resistant in other countries. So what are the consequences on the bacterial ecosystem in Bichat, in the ICU? You see that the consequences of the consumption of imipenem is the increase of resistant strains. That is clear. And in France, in spite of the message that was rather optimistic that Jean-Christophe presented, what had to happen, did happen, you see. We are above 1% for the very first year. At 1.2, you're going to say it's not much, but it does show that it is increasing. And when we see what happened in Italy in just a few years, in less than 3 years, they went from less than 5% to 31%. So we can really be worried. I was in Grenoble, about 100 kilometers from the border, so we might have been more worried than here, but we can still be rather worried about the future. So on a daily basis, we need to treat correctly the patients, and having ESBL with that can have an increased mortality rate because the treatment is delayed. And here, in this other analysis, not only the production of ESBL and the appropriate treatment in the first 48 hours, this was related to the prognosis. So you see there are a number of other events that do explain this, but I think it's really the inappropriate nature that is very important. In brief, so overuse of carbapenem, emergence of carbapenem resistance, and also infections that are associated with a less frequently adapted therapy and an increased mortality. We want a treatment that is immediately adapted with minimal consequences for the patient first, for our ecosystem, and also for the environment outside of the hospital or outside of the ICU too. So what are the antibiotics available, and what can we say about the carbapenem and the alternatives? Here are the ESBL. So before everything was interpreted, they said if you have ESBL, it's resistant to all beta-lactamine except penem. And you'd had RRR. But when you look at the enzymes that are hydrolyzing most beta-lactamine, they do not have a stable effect. You see here the diameters, even if you do not know anything about biomicrobiology, you see that they are relatively active here. It's also an ESBL. You see that there is a synergy between the CFPIM here with what we call the champagne corks, with synergy with the inhibitor, clavimelate and CVP. So the question is, are these molecules with a big diameter that was interpreted as resistant, can they be used to treat the patients? So here are the new breakpoints. So it's always difficult to understand. So I really presented it several times. Everything changes. You just to try to reinterpret these MICs so that you can ask clinicians to interpret things, but it's difficult. So we really have set new breakpoints that we found in literature for, you see, 1 milligram per liter, cefoxitin 8, Tazo 8, except in the US where it's still 16, but it will go down to 8 this year, and AMC at 4. So it's very important to remember these figures. So Jean-Christophe has already presented this. You see ESBL going up everywhere, coli mainly, but other strains also starting in 2011. So what are the other extra lactamine molecules that can be used? Some very interesting messages here. You see a high percentage of strains that are susceptible to amyclan. It's true mainly for colibacillus, so it's very important. Another message is that we have to forget about fluoroquinolone. We are at 30% of susceptibility, so you're going to say, well, it's not the same in my ICU. Maybe it's not the same in your ICU, but overall these figures are very reproducible in this field. And when you look at the collective of ESBL E. coli in Besançon, 100 strains, susceptible strains, penem, of course, but also fethamicin, nitrofurandoin here, acefoxitin here, phosphomycin, amyclan, tadocillin piperin, Shanta a little bit less, and temocillin here. And then, indeed, we're reaching strains where susceptibility is less frequent. This is very important to know this, you know, for the initial antibiotic treatment. So carbapenem, of course, when you have a very severe situation and you don't know where the patient is infected, if it's extra urinary infection, that will be the first choice. And you need to know also that depending on the strains, and in particular strains that are less susceptible to carbapenem, the susceptibility of others might be less significant. Here you see some mortality rate that are less high. So could we have a de-escalation? Some say yes, some say no. Theoretically, as we do not have a selection on the Pseudomonas aerugina and their resistance to penem, that might be better because of that. And some say maybe it's not as effective and there are some crossed resistance on this mechanism. And sometimes it's not so good, actually. I do not have a clear-cut opinion in this regard, but I tend to agree with the first group. When we look at to see if penems or alternatives get the best results with the meta-analysis, you always have the same. Conducting the same meta-analysis, you take everything, you shake it up, and when you look at all of the figures, they are all below 1. Whatever the study, whether it's significant or not, well, penem get a little bit better clinical efficacy compared to the alternatives. And you see the same thing here with when you look at the alternatives, a nice trend in favor of carbapenems compared to beta-lactamases and inhibitors. You see that inhibitors and beta-lactamine, it goes more in favor of carbapenems. So an important study on the possible therapy with beta-lactamine and inhibitors of beta-lactamase in the treatment. This is a retrospective study. They used series. They took patients for whom they knew the strain was susceptible below or equal to 8 and susceptible to penem. So they compare the empirical group and documented group treated with beta-lactamase, an inhibitor of beta-lactamine, and carbapenem. And TAZO is 8, and AMC is 4, I remind you. So in the end, there was not any difference in mortality, so they were rather happy. But you need to be very careful. If you want to de-escalate, when you look at in detail here, you see that when MIC is at 1 or 2, no problem, no death here in this group. However, at 4 or 8, then you can start wondering if there's something happening. It's not written in the literature, but my gut feeling at this stage, based on 2 studies, this one and another one that I'll show you later, is that beyond 2, and you need to ask for MIC if you have a diameter, be careful. Also, another study here, you look at patients who were treated in an empirical way and then documented by PIP-TAZO. PIP-TAZO, when it's urine, no problem, no matter what the level of MIC, from 8 to even 16, no death. But when you look at the others, an increase of the risk of mortality here. So unfortunately, even if you readapt the treatment for secondary penem, you cannot compensate. So these are also associations. There's no randomization, but we need to be careful. The second message is that when less than 50% of ESBL coli were below 2 milligrams of liter MIC in this study, so no problem if it's about urine, because we have an extraordinary concentration of antibiotics, and even if readaptation is secondary, it's not so good. So here what we have in Bichat, I asked Laurence Armand-Lefebvre to go over all of the strains for which there were some MIC that were considered as susceptible, or because some MIC were requested, because it's not systematically done. You see, lower or equal to 2, 66% for E. coli, for KPC not much, and EB group 3 not much either. What about the alternatives? Cefepime? Well, it's a cephalosporin of the 3rd generation, modified at 1. We have a randomized study also versus imatinib. And here there was no conclusion of equivalence between the molecules. There were failures in 4 out of 13 compared to 0 out of 10. So it's not very favorable. But here, in favor of cefepime, we see that there was less C. diff, and also there is some strains that were resistant, Pseudomonas aeruginosa, more often. So a slight benefit, but no real success. And this second study actually complements what was shown in the first one. That is, when you look at MIC for cefepime, you realize that when MIC is below 1 or equal to 1, we manage to do something. But starting with 1, it's no longer possible. This is why MIC was changed for cefepime over the last few years. Below 1, we can wonder if it's a possible alternative. But really, it can be debated. Why? Because most infections are major inoculum. And you need to know that there is a major concern of inoculum effect with ESBL, because then you cannot treat as well those germs. And it's true for all molecules, even for PNMs. If you have a major inoculum, PAVM, for example, you need large quantities of antibiotics, and the most active antibiotic is true in vitro and also in experimental models. It seems to have a real rationale, this inoculum effect, in the start and the implementation of the treatment. So it might be dangerous to start with this. Can you have a de-escalation? When you, maybe then it's more reasonable after 3 days. Cefam is not as well hydrolyzed with ESBL. We had some hopes with clinical cases, small series giving nice results. However, recent series have shown some emergence of resistance, some clinical failures with one of the possible products. And also we have some reservation here. There are some pharmacodynamics problems. And for severe infection, it should be given at 6 grams probably, and on a continuous basis probably. This is what has been shown by a team in Necker. Temoxilin, it is active on ESBL. It's not marketed in France, only in Belgium and in the UK. You can have it in ATU, but it might not have a marketing authorization very soon. There's a problem with the lab. Phospho, very interesting, very susceptible at the beginning, then emergence of resistance under treatment that is very high, so never as a monotherapy, unless with the UTIs, for example. The TISE, well, we need to keep in mind that indeed it can be susceptible if we want to use. There are more and more data and recommendations towards doubling the load doses. And also the European agency said, however, that this molecule shouldn't be used because it's not as active as others, and we should be extremely cautious. But it can be okay in some specific cases. So new inhibitors that are not really inhibitors, but inhibitors of hydrolactamase are like hadribactam. Avibactam is very well advanced in terms of marketing authorization with a number of studies and data. As for the combinations, it's always possible, of course. So you could have cefoperazone with sulfbactam, for example, or also combinations such as sectavibine atebactam, which is something that is being developed right now. You could also, and there are some experimental models on mice and pyranephrine, showing some nice success with cefomycin and phosphomycin. We have these two molecules. We have a nice diffusion. It's rather interesting. And then we can also think, you know, amiclaz, only 40%. If we have combination therapy, maybe we can actually compensate with amiclan. Interesting thing on UTI outside of the ICU with very specific molecules. I don't think we have to go into the details. So what about the basic structure? If you do not have any sampling that is possible, or if you nothing is possible right now, and you don't know what you're treating. So you use probabilities. Either there is an ESBL colonization in the hospital, not in community, then it's very different. If you have a chronic carrier, epidemics, medical tourism, which happens quite a lot, or a trip in an endemic countries, and you're coming back with many bad things, then probably you should try this kind of treatment. In other cases, for example, including nosocomial infection, as the first line of treatment, it's not very useful if the inoculum is low or if it's a UTI. For patients colonizing in the city, we're not sure about what should be done. There are a number of papers, the Mondor team, for example, that have been shown over the last 2 days, explain that the frequency of infection with ESBL coli in CTXM positive carriers in the community is not very high. So maybe it's not a major risk to have another treatment with an amino acid, but it should be done with caution, of course. And of course, and this you really have to you're not going to use a bazooka to kill a mouse. You need to aim precisely. So you really need to eliminate the focus of infection. So, for example, peritonitis, you tell the surgeon, this is carrier of this, I can't fight it with my antibiotics, you need really to eliminate it. So the risk factors, don't worry, I'm going to keep within the time limit. I think we'll have time for some discussion. So the factors, you know them well. As soon as we're sick, when you have a medical history, you have more risks of having an ESBL. We discussed the tourism, and also, you know, it's very difficult to understand exactly their significance. Here is the persistence of carriers. You see that it's over the long term. In the Mozart study, it's not as long, and we can discuss it later on, but the persistence of carriers, well, it's between 15 minus for patients who left and were discharged while they were carriers, and it's more frequent since 2005-2010 compared to before, as if indeed the coli adapted better to the flora. And another evolution that is very important is that it depends on where you come. When you walk in the street in Pakistan, for example, and you go into the hospital, you have 80% or 90% of carriers of ESBL. So here you see it's a very interesting paper, and you should read it. It's very interesting. You have an overview of the community in ESBL, and you see the risk for all of these population, depending on where you come from. This is very different. So this is what I said about the community coli with ESBL. The risk of infection is rather low. And this is one of the papers of Henri Mondor that was published, but there was also other abstracts that were shown during the Congress. Another very interesting message, the quantity of bacteria in the flora is a good predictor of the risk of infection. If you have many bacteria, gastrointestinal bacteria, then you have a higher risk. So maybe we could update this and use this. So documented infection, how and when do we need to save carbapenems? I think that clearly there's no doubt for the most severe condition patients in case of shock or neutropenia, maybe in case of UTI we can do something, and in case of peritonitis, if the surgeon is happy, and we should have an early identification. It's ongoing. There was a very nice review of literature. Aminosine do not change everything. If you use them, be careful about the dose. 25 milligram per kilogram in the loading dose. And this study was done in Bichat, and you see that we reach concentrations that are acceptable, 90 times MIC in many cases. And the more severe is your patient, the more you will have trouble having some rates that have a good efficacy. You should treat only infection. This is very important. You should also optimize the pharmacokinetics. You should ask for a mix, really always, even if the lab sometimes is not very responsive because they don't want to have this mix done. You need to extricate the focus of infection. You should also keep in mind the fact that the situation is dangerous. Any gram of active molecule is important, so the duration of treatment also should be reduced using other recipes, whatever you want. It's very important. Also, we should ask ourselves this question every day. This is the best solution. And also, the different classification of antibiotics not have the same weight, probably. We will discuss that later. So when you look really at the prescription, you can reduce the duration. In Mondor, for example, they had a group of stewardship for antibiotics. We have a medium lag time of 2 days with very often some de-escalation. So this might be the solution for the future. Thank you.